So good morning to each of you. It's now my privilege to introduce Pierre Mangin, if it is really still necessary, of course. Pierre Mangin, PhD, comes from Strasbourg, a French city very dear to my heart. He is part of the local tradition of medicine and researchers with Jean-Pierre Cazenave, Jean-Marie Frécidé, Christian Gachet, and François Lanza, who made and make major contributions at the highest level to the influence and renown of the French Hemostasis School. He is currently the head of the INSERM Unit 1255, entitled Biologie and Pharmacologie of blood platelets, hemostasis, thrombosis, and transfusion. He is also the scientific director of the French Blood Bank of the Région Grand Est. He was the chair of the Scientific and Standardization Committee on Biologie of the ISTH from 2017 until 2022, and is currently theme leader on diagnostics, omics, and advanced technology theme committee for the ISTH. He is on the organizing committee of the French team on platelets and megakaryocytes, and he is on the panel of the upcoming European Platelet Network meeting. His research focuses on providing a better understanding of the adhesive properties of blood platelets, with a focus on the GP1b9 complex, GP6, and integrins. His group is investigating the role of these receptors in hemostasis, arterial thrombosis, and beyond, combining fundamental research to translational and applied research. It's now time to give him the floor, so Pierre Mangin. Thank you.
Thanks a lot for this kind introduction, and I would like also to thank the organizer, Franck Simon, for inviting me today. I think it's a great meeting. Bringing people from different fields together is fantastic. And in the lab, we've tried to, we are mainly biologists, and we are trying to interact more and more with physicists. It's difficult. We talk different languages, but it's very important. So that's a great meeting for that. So I've been asked to talk about arterial thrombosis. And when we think about arterial thrombosis, a key player are blood platelets. And this is really the focus of the lab I'm coming from. We are studying them since more than 40 years now. And we are trying to study every aspect of blood platelets, from physiology to pathology, whether we're talking about their hemostatic function, their role in thrombosis, or even beyond, in inflammation, or in tumor metastasis. But today I will try to focus on arterial thrombosis. So platelets have this typical discoid shape that you can see here on this transmission electron microscopy image. What we know is that there are about 3 micrometers in diameter, 1 micrometer thick, and you actually have a lot of circulating platelets in the body. And it ranges between 150,000 up to 450,000 in individuals. And when you think about it, that's a lot, because it's really a clinical issue when you are below 30,000 platelets per microliter, and thrombocytopenia is considered when you are below 100,000 platelets per microliter. So we could still wonder why we have such high numbers of circulating platelets. The lifetime is of 7 to 10 days. And let's go a little bit inside platelets. So they are anucleated, and they have lots of organelles. So they're really well structured, with first a ring of microtubules that you can see here and there at the edge, so all around the platelet. And this shapes really this discoid or lenticular form of the platelets. You have the open canalicular system, which is considered as a reservoir of internal membranes. Very important during platelet shape change, because when actually this is a resting platelets, but when they become activated, they will contract, extend filopodia, what you see here. And this contraction and filopodia extension is very important to help platelets to adhere to surfaces, but also to form the aggregates. They are like probably little arms. So this system is very important to provide the necessary membrane to do so. Then 2 other very important organelles are the granules, alpha and dense granules. They contain many agents, adhesive proteins, cytokines, chemokines, growth factors, etc. Dense granules, you can find a lot of platelet agonists such as ADP, ATP, very important in sustaining platelet activation. So that's a very important step. When they become activated, they release that. And you know, platelets are viewed like sponges when they are circulating, so they will absorb a lot of components of the plasma, but also like grenades. So as soon as they adhere and become activated, they will release their content to have a very rapid reaction at site of injury. And then you can also find some Golgi, lysosomes, and mitochondria. So I would like to show you a video of FIPSEM microscopy. So this is a dual beam microscope that we have now since 10 years in the lab. So you have basically what this system is doing is actually taking an image and then removing a part of, on the image is scanning electron microscopy, and then removing a part of the platelet, and then taking another image. So it allows you to go through a cell here, the platelet, and gives you quite interesting information about, we can look at it again, about the internal structure of platelets. And it helped a lot as researcher in the lab, Anita Ekley, to define the number of granules that are in platelets. So in blue you have the open canacular system, and in blue and dark blue and yellow you have the granules. So let's go to the function of platelets, and very difficult to start with arterial thrombosis without talking about hemostasis first. And the process by which platelets ensure hemostasis is really well known. I'm going to subdivide it in 3 steps. So you first have the adhesion, then you have the activation, and then the aggregation. And the objective is to form a plug that will seal the breach after a lesion. At this stage, so when the plug is formed, this is called primary hemostasis. Then some of these platelets, I've represented here, one here, they become procoagulant. So they're not all the platelets, just few of them. They have different names in the literature, but we can call them balloon-shaped because they have a very specific morphology. And they will expose, and Keith mentioned it yesterday, a negatively charged surface, allowing coagulation factor to concentrate here and to facilitate the cascade of enzymatic reaction, which is coagulation, so secondary hemostasis, and ending by the generation of thrombin. Thrombin is the most potent platelet activator, but it's also the end product of coagulation, which will cleave fibrinogen. Fibrinogen is the glue between the platelets, so when they aggregate to fibrinogen, notably. And it will cleave fibrinogen to form an insoluble fibrin network, and this will stabilize the clot. Okay, so first we have the formation through platelets, primary hemostasis, and then secondary hemostasis, generation of thrombin, and stabilization of the clot. Now let's go in not every molecular aspect, but like the most important, at least that will come back in my presentation. So these different steps: adhesion, activation, aggregation. So one of the first steps is the attachment of platelets, and this occurs through a platelet-specific receptor. We heard about it yesterday, GP1B95, binding to von Willebrand factor, which is a plasma protein, but also found in the subendothelium. And this step is key, especially when the blood flow increases. So higher the blood flow is, more you are going to depend on this interaction. And when you exceed wall shear rates above like 1,000 inverse seconds or 1,500 inverse seconds, the interaction relies completely on the GP1B95 VWF complex. So this is the attachment, and then you need them to stably adhere, because we heard yesterday that this interaction is unstable. And this is done, I haven't represented here to not add too much information on this slide, but this is ensured by integrins, and platelets have 5 different integrins, and they will allow this step of stable adhesion, and there is already an initiation of platelet activation. Then once platelets are stably adhered, here I'm going to mention a receptor which is called GP6, we'll come back often in this presentation today, that will interact with collagen and really initiate the processes of platelet activation. So this is directly through a signaling pathway, but also indirectly through its potential to release soluble aggregates. Amongst them, you have ATP, ADP, thromboxane A2. They will act back to platelet receptors. They are identified, P2Y1, P2Y12 for ADP, TP for thromboxane A2, and reinforce platelet activation. But actually, what is platelet activation? So the first sign is the shape change. I showed it before, mentioned it here. Second sign is the release of the content of the granules, ADP, for instance, ATP as well, but also the potential to release thromboxane A2. So here we are on what we call the amplification loops. So this is activation, but reinforces the activation. But at the end of the day, a very key step of platelet activation is to act on this integrin, alpha-2 beta-3, important in adhesion, but also in aggregation. And what activation is doing is increasing the affinity of this integrin for fibrinogen, so allowing platelets to bind together. Now, this molecular mechanism is the same that is occurring in pathological condition, in a diseased vessel, presenting a plaque. So atherosclerosis is a disease, a vascular disease that occurs in almost everyone, only in certain places in the body, starts quite early on in life, accumulation of lipids in the wall, and then it ends up, I don't go in details, but it ends up with the formation of atheroma or plaques that induces a stenosis. And at one stage, when they are evolved, so later, usually later on in age, it can rupture. And when it ruptures, platelets circulating in this vessel think, oh, here is a signal, probably bleeding, I have to stop that. So they will do their job. They will adhere, become activated, and aggregate. But under this condition, aggregate formation can become occlusive. And this is for several reasons. First, there is a stenosis. So there is, to get an occlusion, it's much easier than in an open vessel. Also, because of the stenosis, the flows are profoundly modified, and this has been really deeply investigated. You have flow acceleration in the prestenotic region. You have very high shear in the stenosis throat, and you have regions of recirculation in the poststenotic area. And all these flows are prothrombogenic. And then finally, the material that is exposed after a plaque rupture is very thrombogenic. You have lots of tissue factor. We heard about it yesterday, activates coagulation. You have lipids, a lot. They can activate platelets. And you have lots of overexpressed adhesive protein, notably collagen. So in this situation, you can have formation of an occlusive clot, and this leads to ischemic disease. So which ones? This depends on the vascular territory. You have myocardial infarction if you are in the heart. So when you occlude a coronary artery. So in France, it's 80,000 cases per year, 12,000 deaths every year. You can have a stroke. So here it's a bit different because this is a clot that blocks cerebral artery. But usually this clot is not forming in the brain. It's coming either from the heart or from an ongoing thrombosis in the carotid. It's just in the Asian population, they can have some atherosclerosis in the brain, and the clot can form directly there. But usually it's a clot coming from elsewhere and blocking a cerebral artery. So 110,000 cases per year, 40,000 deaths a year. And then we talk less about it, but it's still a concern, peripheral arterial disease. So we are here in the lower limbs. There can be a lot of atherosclerosis. It's quite impressive. Sometimes people have atherosclerosis from the beginning of the leg until the end of it. So it's very, very impressive. We estimate that today there are 800,000 cases in France, and this leads sometimes to amputation. So if you're not having blood supply in in the legs. So these pathologies are all caused by a clot, a thrombus, that is composed of fibrin, red blood cells, and of course very rich in platelets. So this is why treating arterial thrombosis relies notably on antiplatelet agents. So there are three main classes of antiplatelet agents. The first one developed a very long time ago is aspirin. I don't go in details, but it blocks a signaling pathway that allows to release thromboxane A2. I mentioned it before. That goes back to TP. So this is blocking platelet activation. Second one, also blocking platelet activation. This is a class of inhibitors that block the P2Y12 receptor, ADP receptor. If you remember well, this is released by platelets after activation. And the inhibitors are clopidogrel, prasugrel, ticagrelor, cangrelor. So here, two targets that inhibit platelet activation. And the last one, much more potent, are the alpha-2 beta-3 blockers. So here, we directly block with this agent the end step, which is platelet aggregation. So alpha-2 beta-3 is the receptor of fibrinogen. And today, in most of the cases, the standard of care is the combination of aspirin with a P2Y12 blocker. And overall, it works quite well. No doubt that it helped to reduce morbidity, mortality linked to arterial thrombosis. However, there are still some issues, and notably bleeding, right? So the main complication, increased bleeding risk. Sometimes that's not enough. So what has been developed is endovascular approaches, and this is notably angioplasty with stenting. So what the clinician is doing here is entering a catheter with a balloon at site of either thrombus formation or where you have a plaque, inflates the balloon, so pushes the plaque towards the wall to reopen the vessel. This is very important to allow a normal blood supply. And then in order for the vessel not to collapse and to stay open, they install a little metallic grid that is called a stent. Of course, you can imagine that if you implant a stent in a vessel, that might be very thrombogenic. So this is going along with a pharmacological approach. I just mentioned it before. Usually dual antiplatelet therapy. Aspirin is a P2Y12 blocker in the heart and the lower limbs. Sometimes in the brain, clinicians prefer to use monotherapy with aspirin. Because actually, if you do bleed in the heart or in the lower limbs, it's okay, it's not too bad. But if you start to bleed in the brain, it's pretty bad. You can die from it. So it's very dangerous. So they are still very, very cautious on that. Now, even for this intervention, so angioplasty with stenting, that also is very, very efficient, there are issues. And one of the issues is stent thrombosis. So this is defined by the formation of a platelet and fibrin-rich thrombus directly in the diseased vessel where the stent has been implanted. It can be acute, it's often acute. So in the 21st hour, sometimes the clinician can see it directly on the patient while he's still working on this case. It can be subacute within 1 and 30 days. They are also called together early stent thrombosis. It can then be late or very late if it's between 1 month and 1 year or after a year. Now, the prevention of it. I mentioned it before, dual antiplatelet therapy or monotherapy with aspirin. It works really well. If we look at dual antiplatelet therapy in the heart, we are now lower than 1%. It's actually, most of the time, 0.7% of stent thrombosis. If you talk to clinicians, they say, we are not going to do better than that, which probably makes sense. However, there are still consequences. Depending on the papers you can read, if you do a stent thrombosis, it's really bad. You have 10 to 40% of chances to die. Sorry. If you then look at the lower limbs, pardon. The incidence is higher, 6.1%. And when you look in the brain, carotid artery, it's 18%. So 1 patient out of 5 is still having stent thrombosis. So there is really room to improvement. And the reason for that is, I just explained before, it's because we are only using aspirin. So probably the anti-platelet therapy that is used is not aggressive enough. And on top of this high incidence, you can also have amputation and disability. So it's pretty bad for the patients. Good. So let's go now to, after this introduction, to the talk. First, I would like to start with talking about the models that are used in the labs to study platelet function and then platelet in arterial thrombosis. It's going to be quite short, but just to discuss a couple of the models. Then the two important parts will be one on this aspect of the antiplatelet treatment. I said it before. They're working fine. For some of the pathologies, I think there's no room for improvement, but they are for other pathologies. And we are still looking for safe anti-thrombotic drug. And I would like to take you to a quest we have since 25 years, focusing on one receptor. So that's 25 years of research on GP6. And show you from the beginning, so at the identification of this receptor, development of antiplatelet agent, so anti-GP6 agents, and then evaluation in clinic. And actually, we had the results earlier this year, and this is now coming back to research labs, so quite interesting. So I will take you through this. So this is over 25 years of work. And in the last part, I will focus on the stent thrombosis. So this is more recent work in our lab, and show you some of the models we developed to ask the question, what are the mechanisms? So first, let's go to the models to study platelet function in arterial thrombosis. So difficult not to mention aggregometry that has been developed in the 60s by Gus Born. And you have here the first aggregometer he developed. And this tool is quite fantastic because it's now used for many, many years. It's used in diagnostic, but still in research lab. And it's a very simple device where you use a cuvette in which you have a suspension of platelets, and you measure the line's transmission through it. And you end up with this type of curves, very informative. So when you add an agonist to a suspension of platelets, they will change their shape. I mentioned it before. And this will modify the light transmission. And then they start to stick together, aggregation, and it also modifies it. So it's a very simple system. You can get this curve, and as I mentioned, we got a lot of information out of it, especially the role of a soluble agonist, and it's still extensively used. However, it has a huge limit. It does not reproduce a thrombus, how it forms in vivo. And at the beginning of my talk, I mentioned about VWF. We heard about it yesterday, and GP1B9. If you block GP1B9 and VWF in this system, in response to all soluble agonists, you have no effect whatsoever. So this really clearly highlights the fact that this system, because of the absence of flow, can give some information, but is not complete. So now I would just like to show you one scheme here about the importance of blood flow in thrombus formation, and provide some evidence that it's actually having an impact on every step. And first, the adhesion. So what we know is that flow can, by the forces generated, can unfold proteins. Keith mentioned it yesterday, and notably VWF. So when VWF sticks down and you have flow forces, it will unfold, expose cryptic site, and this is what allows GP1B to bind. So flow is directly impacting the interaction between GP1B and VWF, and that's why it's not working in the aggregometer, because you don't have the forces necessary to unfold VWF. Flow is also regulating activation, first in a positive way. It can act on receptors that are mechanosensors and that will induce signals, biochemical signals, promoting platelet activation. But actually, flow is also negatively regulating activation. As I mentioned before, during the process of thrombus formation, there are lots of agonists that are released, ADP, ATP, thromboxane A2. You have all the coagulation factors of the blood that concentrate here. Thrombin that is generated, most potent platelet activator. And what flow is going to do is to wash them out of the system, to avoid an excessive response at site of injury, and to avoid the formation of an occlusive thrombus at site where you just need a repair. Because if you have a hole in a vessel, all you want to do is cover here this region to form a plug, not to form an occlusive thrombus. You need the blood to continue to flow. And finally, aggregation as well, because when platelets start to aggregate and a thrombus is forming, bigger the thrombus is, stronger the forces are on this thrombus. And this could also lead to embolization, which can be actually an advantage. I'll probably talk about it later. So, okay. So now, what else do we have in the labs to study platelet aggregation, thrombus formation? And here I would like to mention a blood flow assay. So I really show the most simple assay, far from what many great groups in the field, including his group, have developed. That's classical blood flow assay. So you have, and as we're using it in our lab, here you have the syringes with blood, buffer, and then the blood is aspirated through a flow chamber thanks to a programmable syringe pump. So very simple system. And then the chamber is just placed under a microscope. So here we coated with a weak adhesive protein. And what you can see here is over time accumulation of platelets. So once you've done this type of experiments, you can actually have lots of information out of it. First, on adhesion. You can, for instance, count the number of platelets adhering over time. The behavior of this adhesion. So here you can see it's mostly stable adhesion. But sometimes the platelets are rolling over the surface. Sometimes they detach. So you can have this type of information. When they roll, you can measure the rolling velocity. You can also have information about activation. So this type of images, if you zoom enough, you can see the shape of the platelets. They can be discoid, so only non-activated or weakly activated, shape changed, extend filopodia, spread over the surface. So you have all a range of morphological modification that you can get. But we also have markers of activation, and they really recapitulate the different steps of platelet activation. You can look at whether alpha-2 beta-3 is activated. You can look if P-selectin is exposed. This is a marker of granule release. Sorry. And then also whether they become procoagulant. We have markers such as annexin 5 that stains procoagulant platelets. And finally, what you can do is coat highly reactive protein on the surface, such as collagen. And then what you see is platelet aggregation. Okay, so this is an in vitro model. Now let's talk about in vivo models. So we have lots of different in vivo models, mainly in mice. So there are different ways to injure a vessel. We can use chemical ways, so ferric chloride. We can use mechanical injury, forceps, a needle injury. We can also use a laser. And there are different vessels that can be targeted, large vessel, carotid artery, the aorta, but also very small ones, so the microcirculation, mesenteric arterioles, cremaster arterioles. And then you can combine it to intravital microscopy. So you can, for instance, here stain the platelets, that's what we did here, in green and fibrin in red, and you can look over time how a thrombus is forming, and you end up with this type of curves showing you the thrombus formation and the fibrin formation within the thrombus. Good, so now that I talked about the model, I go back to this scheme here about the antiplatelet agents. And I would like to talk about one specific receptor, that is glycoprotein 6, that we have been working a lot in the lab. So let's go in detail. What is GP6? GP6 is a member of the immunoglobulin superfamily. We know that, we know that it has two IgG-like domains that actually the binding sites for collagen. We know that it's specifically expressed on platelets and megakaryocytes. It's the main platelet activation receptor for collagen, but we know now since a couple of years that it's also a receptor for other adhesive proteins, fibrin, fibrinogen, laminin. It is coupled to the Fc receptor gamma chain, and this is important for its surface expression, but also to induce this signal I mentioned before that is important for platelet activation. So here is the important part. GP6 is really a platelet activation receptor, not an adhesion receptor. Very efficient in release of soluble agonists, so these amplification loops. And then it promotes platelet aggregation and procoagulant activity. So it's doing a lot of things. Now the question, what do we know about GP6 in hemostasis? So the first couple of data are from the 1980s, 90s, with the identification of patients that developed anti-GP6 antibodies. And they observed that these patients do not respond to collagen, and they identified that the missing receptor is GP6. And what they observed is that this patient exhibit only a mild bleeding diathesis. So really far from patients that don't have GP1B on their surface, called Bernard-Soulier syndrome, or alpha-2 beta-3, Glasman thrombosthenia. Then, later on, 3 papers have been published, so that's not much, with identifications of patients with mutation in the GP6 gene. And I just would like to mention this one, which I think is very important. This is coming from Chile and from the group of Diego Mezzano. He identified an adenine insertion in exon 6 of the human GP6 gene. And this generates a truncated protein that is not expressed at the platelet surface. And he showed that this patient had a bleeding disorder. And what is interesting here is that he described 5 patients from 4 unrelated families. So this strongly suggests that there is a founder mutation. And more recently, the group of Neil Morgan did some estimation of that. And he proposed that probably over 4,000 people in Chile, so 4,000 individuals, do not have GP6 on the platelet surface. So this paper was published 11 years ago, and since only 8 people came to the hospital with bleeding issues related to the absence of GP6. So that's a very strong argument to suggest that when you don't have GP6 on the platelet surface, you can live completely normally. So along many other information, GP6 is not strictly required for physiological hemostasis. Now, what about arterial thrombosis? If you go to textbooks, if you go to reviews, you always see GP6 is very important for arterial thrombosis. But even though I'm a big GP6 fan, I will try to show you a bit in more honest way what really has been published in the last 15 years. And this is one example. So on the top, we have the result of work from Christophe Dubois, now in Marseille, before in Bruce Fury's lab in the US, and from our group. So we both use mice that don't have GP6, and both submitted them to a ferric chloride injury model. Christophe found that they were protected. We didn't find any difference. So how can we explain that? And that's where it's very important, whatever you do, to characterize the model you have. What Christophe showed is that in his model, collagen is exposed. So there is a denudation of the endothelium, and no surprise that he sees an inhibition in these mice that have no GP6. Sorry. Sorry. So in our model, we are actually applying the ferric chloride injury in a much sicker injury. Here we are talking about the mesenteric arteries. Here it's the carotid. And what you can see here in gray with the stars here are ferric chloride bubbles going through the endothelium. And in dark gray, you can see the endothelium that is intact. So what happens here is that ferric chloride is going through it, there's no denudation of the endothelium and no exposure of collagen. So no surprise that here there is no difference. So this is one explanation. And then there is another one, and I think this one is much more important. So here what we used is a laser injury model of mesenteric arterioles. So we use a laser, we just remove 2 endothelial cells called the superficial injury model, and you can see here in green a thrombus formation. But we also have a way to induce a severe injury. So we basically just open the vessel with the laser, expose the inner layers, and look at thrombus formation. So when we use the FCR gamma chain knockouts, so GP6 knockouts, no difference compared to wild type. On the superficial injury, we had a decrease, but very minor. So it seems not that GP6 is very important here. However, if you do the same experiments and you treat the mice with hiridine, which is an inhibitor of thrombin, so a potent platelet activator, then all of a sudden you see a role for GP6. So what does it tell you? It tells you that in this model, GP6 plays a role, but it's not just major. It also tells you that the importance of GP6 in thrombosis will depend on the stimulus at site of thrombus formation. If you have lots of agonists there, notably thrombin, the role of GP6 will decrease. Good. Now one of the limits of the models I showed so far is that the injuries in the mice are applied on healthy vessels. But as I mentioned before, thrombosis are on plaques. And I think these two papers were very, very important. The first is from Johan Himskirk, who used ApoE deficient mice. So these are mice developing plaques. Here you have the carotid arteries of mice, and you can see here in white a plaque. And what they did is use an ultrasound probe to injure the plaque, and then in real time they looked at thrombus formation. And when they treated the mice with JAK1, which is a very important tool in the field that induces an immunodepletion of JP6, they have a very strong inhibition. So this work was then confirmed by Beatrice Eschler in our group, but she also developed a model of plaque rupture using a needle going through the plaque and then getting into the vessel and scratching the plaque. And here again, she observed thrombus formation in real time. And when the mice, ApoE deficient mice, were treated with JAK1, she has a reduction in thrombus formation. Okay, so here, what are the results we have? It seems that JP6 does not play a minor role in does play a minor role in hemostasis, but seems very important in atherothrombosis. Now the question is, how can we explain that? Because if you target platelets, they should play a role in both situations. And what we think is not a question of targeting platelets, but it's the ligand that is very important. And that's probably where the difference is. So in healthy vessels, you have collagen, but in plaques, the collagen is overexpressed. So it is possible that when you have a plaque rupture and lots of collagen, you have a response that is very much JP6 dependent. And if you block it, you have a very nice inhibition. Good, so this stimulated everyone to develop anti-JP6 agents. And there are two main strategies. And the two strategies here were translated in clinic. First one is Cept. It's a JP6 mimetic. So it's a fusion protein of a dimeric JP6. So basically, the extracellular domain of JP6 fused to the Fc part of an antibody. So that's a competition approach. So actually, this molecule binds to collagen and prevents platelets to adhere. Again, the name is Cept and developed by Advanced Core. And then you have also another approach. So the agent was first named 912, then humanized named Acto17, and finally Glenzocimab. And it's a Fab fragment of an anti-JP6 blocking antibody. So here, this agent is directly going to JP6 and blocking it. And it is developed by Arcticor Biotech. Okay, so already 20 years ago, Martin Gendreau-Pérus in Paris developed this agent, first called 912, and used the blood flow model I presented before, in which human whole blood is perfused over collagen. In white here, you can see thrombus formation. And when she adds to it 912, she has a very nice inhibition of thrombus formation. Great. A couple of years later, our group did the same experiment, but this time ex vivo in non-primate monkeys. So here we treated monkeys with a control, or 912, collected the blood, perfused it here in this system, and we also had a reduction in thrombus formation. That's all nice, but that's in vitro. So then we wanted to move to in vivo work. So what we did is we developed a knock-in, a humanized model for JP6. Why? It is because this agent only blocks human JP6. So what we are doing here is just replacing the mouse gene for JP6 by its human counterpart. So this mouse is completely normal. I don't have time to show the result, but has human JP6 at the platelet surface. So I don't show at all the characterization, but again, all the platelet function, platelet count, everything is normal there. Then we evaluated these mice in two models that are sensitive to JP6, laser injury model and mechanical injury model. And what we observe is thrombus formation that was reduced in the presence of 912. So nice inhibition of thrombus formation. And in the same time, we evaluated the impact on hemostasis. So as the discussion yesterday was on bleeding risk, we would love to look at the bleeding risk. We have no idea how to do it, but at least we can look at hemostasis. And when we use two doses, quite important, of 912, we have no impact on the tail bleeding time. So what we do here is basically you treat the mouse with 912, and then you cut 3 millimeters of the tail, and you look how long it bleeds. You can also measure the volume of blood loss. So no impact seems to be promising. Then we went to the atherothrombosis model. So here what we did is use the bone marrow of humanized JP6 mice and transferred it in 1-year-old irradiated ApoE mice to end up with a mouse that has plaques and circulating platelets with the human GP6. Subjected to the needle injury model, you can see here thrombus formation, and when it's treated with glenzocimab, you have a very nice inhibition. Okay, now what about ischemic stroke? So let's first just very rapidly talk about this pathology. So ischemic stroke occurs when a thrombus blocks the cerebral artery. And there are two ways to treat it. Since 30 years, people are using RTPA. So this is a recombinant agent that will actually dissolve the clot. So this clot is composed of platelets, red blood cells, and a lot of fibrin. And this agent here is cleaving the fibrin. So the idea is that if you cleave the fibrin that holds the thrombus together, you dissolve it. So this thrombolysis treatment is great. However, the eligibility is short, 4.5 hours. So this means that if you go to bed in the evening and you wake up in the morning with a stroke and you have no idea when the stroke onset was, it's probably too late for you to have thrombolysis. And on top of it, the recognition rate is pretty bad. It's only working in 1 patient out of 3. And that's the only pharmacological treatment we have so far. Since 2015, and a clinical trial called Mr. Clean, another standard of care now is thrombectomy. So here, what clinicians are doing is inserting a catheter and removing the thrombus. So the eligibility is a bit longer, it's 6 hours. Localization rate is much better, 75%, but it's only suitable for large arterial occlusion. So there are some regions where they cannot go. And 75% they would like to do better. So there is still the need for additional treatments, and potentially anti-GP6 treatment would be great here. So is it the case? What do we have? What has been shown in literature? So a long time ago, the group of Kleinschnitzer and Nisvan evaluated the role of GP6 in ischemic stroke. And for that, what is usually used in the field is the transient middle cerebral arterial occlusion model. So it consists in inserting a guide wire until the middle cerebral artery, block it. So there is no blood supply for 45 minutes to 1 hour to a part of the brain, and this part of the brain will die. And at 24 hours, you use a TTC staining, and you look at the healthy part in red of the brain and the dead part. And you can see here that there is the part of the brain is indeed dying in this mice. And when they treated the mice with JAK1, I mentioned it before, so it's an immunological knockout, to say so, you have a very nice decrease in the infarct volume. So they concluded that there is a decrease in infarct volume and no hemorrhagic transformation in JAK1 treated mice. So it seems to be great. So this stimulated Acticore Biotech that develops the glenzocimab to go to, with the molecule, to go to ischemic stroke. And they have done a phase 1b/2a study named Actimis in ischemic stroke patients. So the objective was to evaluate the safety of glenzocimab added to recanalization procedure, thrombolysis and thrombectomy, within 4.5 hours of an acute ischemic stroke. First phase was escalating doses of glenzocimab, ranging from 0 to 1,000 milligram, IV infusion, and they concluded to a good safety, so the highest dose was chosen for the second phase. And here they compared glenzocimab to placebo in patients eligible for therapeutic recanalization. Primary endpoint was safety, secondary endpoint severity score, and neurological disabilities. And the work was published very recently. Let's go, and I summarize here the result of this trial. So adverse events, nothing in the glenzocimab arm compared to placebo. The huge surprise was that intracranial bleeding was reduced in the glenzocimab arm, both symptomatic and unsymptomatic, compared to placebo. So there is less intracranial bleeding in the glenzocimab arm. So this was a real surprise, because usually when you use an antiplatelet agent, you will expect more bleeding. The hope here was to have no more bleeding, but having less bleeding, that's really surprising. So this has a direct consequence on the death of the patient, there was a decrease in the number of deaths in the glenzocimab arm, and also reduction in the most severe handicap at 90 days, which is usually evaluated. So even though this trial was on a small number of patients, very, very promising. So then I indicated here in red, because I will talk about it, they also observed the MTK3 score. So this is something that talks about recanalization, whether the blood flows again correctly. 44% in glenzocimab arm and 30% in the placebo arm. So I summarize here the results and the hypothesis. So it seems that glenzocimab could have two modes of action. The first one is an add-on effect on recanalization because it improves it. So their hypothesis is that it might inhibit platelet accumulation at site of fibrinolysis. So you have the clot, they are doing fibrinolysis, RTPA will cleave the clot, and glenzocimab helps. They think their hypothesis, I don't think it's correct, but we will discuss it. The hypothesis of Acticore Biotech is that it inhibits platelet accumulation after fibrinolysis. And then, because they have a reduction in intracranial bleeding, the idea is that there is an inhibition of the thromboinflammatory events in the downstream circulation. And this will then prevent hemorrhagic transformation. Good. So that's basically where we stand since a couple of months now. And that's interesting because now it's in clinic and it comes back to research because we see a very nice effect of a molecule in a small trial, but we don't understand completely what's going on. So this work is now going back to the lab and we are doing work on it. So we are working on both aspects to try really to understand the mechanism. And today I will just talk about what we did recently on this add-on effect. So how can the add-on effect of glenzocimab on recanalization be explained? Now, I told you that this clot is coming from elsewhere, blocking a cerebral artery, and there's no injury here. There's no collagen exposed, and GP6 is a receptor for collagen. So how can actually this be explained? It makes absolutely no sense. And at the beginning of the talk, of this part of the talk, I mentioned that GP6 is also a receptor for fibrin and fibrinogen, and that's our hypothesis. So very briefly, we showed a couple of years ago that GP6 is a receptor for fibrin. We have lots of lines of evidence. One of them is using the flow-based assay, immobilizing fibrin, perfusing blood over. You see platelet adhesion, very teeny tiny aggregate, not much. And when you use GP6 deficient mice, so mice without GP6, you have less platelet aggregation. We also showed that GP6 is a receptor for fibrinogen. And this is done in this experiment. So we know that the main platelet receptor for fibrinogen is alpha-2 beta-3. So what happens when you have human platelets? You immobilize fibrinogen and let platelets adhere. They will stick to it. They will change their form, and then they will spread over the surface. This is what you see here. And the surprise came from the fact that when we did this same experiment with platelets from GP6 deficient patients, we had the adhesion. No surprise, because it's through alpha-2 beta-3, but they're unable to spread. And the spreading is through alpha-2 beta-3. So this tells you that GP6 induces a signal, because it's just an activation receptor, that will allow alpha-2 beta-3 to become activated and to allow this spreading. Good, so GP6 activates platelets through fibrinogen. But just knowing that they induce spreading is not very informative. So we questioned that. What is the potential of this interaction? So the first experiment we did is we perfuse whole blood in the flow system of a collagen from the aggregates in gray, you can see here. And we measured the volume. And then we continue to perfuse blood, the exact same blood, in the presence or absence of the anti-GP6 blocking agents. In the control, we had thrombus growth, which we measured here. When we treated with active 17, no thrombus growth anymore. You can see in orange here that platelets are adhering, of course, because you have this important receptor I'm talking about since the beginning, GP1B and alpha-2 beta-3. But there is no growth. They're just here to adhere and no enough activation to allow platelet aggregation. So GP6 fibrinogen is important for thrombus buildup. But that's not it. We also think it's important for thrombus stability. And here we did another experiment perfused blood over collagen, so same as here, but then rinsed to get rid of the blood. We use the shear rate that allows platelets to remain stable under this condition, and then we injected the anti-GP6 agent. And you can do this after 1 minute, 5 minutes, 30 minutes, or an hour. You have exactly the same result. So here you have the step of platelet adhesion. You can see the aggregates are forming and contracting. And here we inject Acto 17. So they are stable there, and they completely disaggregate. So this tells you that the GP6 fibrin interaction is important for thrombus stability. It also tells you that actually what happens is that you have a continuous signal to GP6, while before the idea was that GP6 really initiates the process of thrombus formation. You probably have a continuous signal to GP6, and when you don't have the signal anymore, then 2B3A comes back in a low affinity state for fibrinogen, and the thrombus is disaggregating. This is also potentially explaining what happens during stroke, is if you block GP6, less signal, platelets are less activated, and you have a disaggregation. Good, this is in vitro. Can we prove it in vivo? I showed you this slide before. And these are the different models we have. So when you look, there are all different types of injuries in different types of vessels. But overall, when you look at the dynamic in green of platelet formation, you always have the exact same shape of the curve. So you first have a growth and then an embolization. This always happens. And the reason why you're forming such a large thrombus to end up with a small one is most likely because you want to have like a shelter to allow coagulation inside and fibrin to form. Now, the problem we have here is we would like to see what happens when you add an anti-GP6 agent on a formed thrombus. And this is in vivo, so not one curve looks like the other one, so it's very complicated. So the question here is, if we don't have a stable thrombus formation, it's going to be very difficult to see the effect on anti-GP6 agent. What we need is a stable thrombus formation model. So we decided to work on it. And what we decided to do is to concentrate the activation very strongly on just one portion of a vessel. So we developed a model of pericloral injury on the carotid artery with 2 sites of injury. So we basically come from both sides. Also, what we implemented here is not just looking at platelets, but also fibrin and red blood cells, because if you have a stable thrombus, an occlusive thrombus, you will have accumulation of red blood cells. So platelets are in green, fibrin in blue, red blood cells in red. So what you see here on this video is first platelet arriving, then rapidly you have fibrin forming in blue, and then when the thrombus becomes stable, you have red blood cells accumulation. So what you have to realize here, it's a very short video, but it's over 45 minutes. That's a very long time to do a thrombosis model. So we characterize this model. Here you have the curve, so for platelets arrived, and fibrin that stabilize the aggregates, and then red blood cells. And if you combine all the signals, then you have a curve that is more flat, and on which you then will be able to add antiplatelet agent to look at the stability. So this is just to show the characterization of the model. I will be brief. Here you have what is important here is that you can see in gray here the thrombus. This is the vessel wall. This is the thrombus. And in dark here, there are the beads of ferric chloride. You have the beads just here. And this is just to show that, as we published a long time ago, in this model, we are not exposing collagen. OK, so is our model sensitive to antiplatelet agents? Because if we form such a huge clot that is insensitive and not finally platelet dependent, we will not be able to test anti-GP6 agents. So what we use is an agent called Cangrelor that blocks P2Y12. And we know that P2Y12 is very important in thrombus stability. So again, what we do here is we let, during 15 minutes, the thrombus grow and become stable, and then we add the antiplatelet agent. So here you have the thrombus forming, and when we add Cangrelor, it completely reopens the vessel. That's a result from last week. Here we targeted alpha-2 beta-3. So we have done it with integrin eptifibatide, but also with a peptide called GR. And again, we let the thrombus form. And when we add GI, it completely opens it. Okay, so the model is able to form a thrombus, a stable thrombus that becomes occlusive. But with these agents, we are able to reopen the vessel. So what happens now with glenzocimab? So here, of course, we have to go to the humanized GP6 model. So here we show only the platelets. And then when we add glenzocimab, it's not as efficient as the anti-2b3 agents and cangrelor, but we also have an opening of the vessel. Okay, so we could think, okay, it's not as efficient, but if you remember well, GP6 is not harming, is not inducing a bleeding risk. So this is interesting, and this might be the reason why in the clinical trial they had such an interesting result, and is promising for glenzocimab. So good. Now we pushed a bit further because we are always interested to understand what happens. And we ask the question, okay, so which mechanism is this done? And this is why I showed you the characterization before. You know that GP6 binds to 4 adhesive proteins. And in the characterization, I told you that the subendothelium is not exposed, which means we can exclude collagen and laminin. So potentially it's a fibrin and fibrinogen. What we would love to have is an agent that specifically blocks interaction with the different ligands, but we don't have such an agent. And most likely, maybe we will develop one, I don't know, but one of the problems is that the interaction regions are very close on these 2 loops. So it's most likely to fibrin or fibrinogen. Can we answer the question? Probably not. However, what we did is we took advantage of a species difference. So what we know is that human and mouse GP6 bind to fibrin, but it's only human GP6 and not mouse GP6 that binds to fibrinogen. So we decided, okay, let's do an experiment with wild type and GP6 deficient mice in this model. And because this model does not expose collagen, we know that thrombus formation, because we published it, is completely normal. But let's have a look at thrombus stability. So first step, is the thrombus forming normally? The answer is yes, we expected it. Is the thrombus becoming unstable? No. So for now, and it's not a definitive proof, but we think that the GP6 fibrinogen interaction is important in thrombus stability. Good. So everything was perfect in the lab, everyone very, very happy. And all of a sudden, a new trial came out. So this is still unpublished. I just have a couple of results from Ecole Biotech. That's the ActiSave trial, still on glenzocimab. So that's a follow-up trial after Actimis. But they did not wait the result of Actimis to launch this trial for many different reasons. You know, it's very difficult to run a startup company, and to do this type of essay, you need a lot of money. So that's a phase 2-3 study in acute ischemic stroke patient. So 400 patients this time. So it's almost the same essay as Actimis. They're all eligible to thrombolysis, and some had mechanical thrombectomy, and then randomized to glenzocimab placebo. And the results are awful, as the primary endpoint, so the proportion of patients with an MRS score of between 4 and 6, so poor outcome, was not reached. The key secondary endpoint, so proportion of patients with MRS score 2, so 0 to 2, favorable outcome, is not reached. So this is a negative trial, and this kills the whole project. On the good side, they confirmed the safety profile. So glenzocimab is now safe, and this has been injected in more than 800 patients, never induced any bleeding. But, you know, I mean, if it's safe and it's not doing anything efficient, what's the point? So then they try to understand what went wrong here. I think first, it could have been interesting to wait the end of Actimis to really identify subpopulation to target and to test glenzocimab. However, it's easy to say afterwards. It's much more complicated when you do the work. Then they identify the limit. So they found out so they had to do this essay on 1,000 patients and decided to cut it down to 400 because they were very confident. But what they observed is there is a limit in their study. There is an imbalance between diabetes and severity score at inclusion. It's more represented in the glenzocimab arm treated by IVT and MT, so thrombolysis and thrombectomy. The other explanation is it has not been done at the same time. The ACTI trial was done just after COVID. Maybe the treatment was slightly different. And 2015 is yesterday. For you, it's maybe a long time ago. But at this scale for thrombectomy, it's yesterday, meaning that there have been lots of improvement in the technique more recently. And then what they also observed is that a postdoc analysis show a much favorable result for glenzocimab on the UMRS score 01 after adjustment for imbalance of prognostic factors in fully recognized patients. So here, I think they try to remain very positive. At the end of the day, this kills completely the project, right? At least the use of glenzocimab in stroke. So does it mean that GP6 is not a good target? No, I don't think so. Does it mean that glenzocimab is not a good product? It could be improved. We know it since a while. But still, I don't think that's the point. The other very difficulty that there is here is that what you have to do is give glenzocimab as soon as you know that there is a stroke. And this is very complicated because in the hospital you need the consent of the patient. Usually he has a stroke, so he will not give it to you, so of the family. So this has a real impact on the effect of glycoprotein 6. Okay, so if this part is dead, are there other potential interesting indications for anti-GP6 agents? There are, and one of them is STEMI, so myocardial infarction. So together with a group in the UK, Mark Thomas, a couple of years ago, we showed that still in the flow chambers, when you perfuse blood over collagen or over atherosclerotic plaque material, if you use glenzocimab, you inhibit thrombus formation. Maybe not as nicely as eptifibatide, this anti-2B3 agent, but you have a nice inhibition. And even though it's not as nice, as glenzocimab is safe, it really could be an interesting agent there. And they launched a trial called Liberate, which is a phase 2B, trial in 200 patients with myocardial infarction, scheduled for PCI, so percutaneous coronary intervention. So that's the guide wire that I insert to install the stent I mentioned before. And it is randomized to glenzocimab or placebo. So they have included 30 patients, so we'll see what happens. So let's go to the take-home messages here. GP6 is a major platelet receptor for collagen, supporting platelet activation, aggregation, and procurement activity. GP6 is also a receptor for fibrin and fibrinogen, and the GP6 fibrinogen interaction is important in thrombus buildup and stability. GP6 is not strictly required for hemostasis and contributes to thrombus formation on atherosclerotic plaques. Glenzocimab showed a nice safety profile and promising result in a phase 1B and 2A study, which were not confirmed in a phase 2-3 trial. And anti-GP6 agents might be interesting to prevent thrombosis in STEMI patients. Okay, now let's move to stent thrombosis. So I move here to more recent work. And, I mentioned before that stent thrombosis is a pathology that occurs when platelet and fibrin-rich thrombus forms in a vessel that has been stented, that has a pathology, so has an atherosclerotic plaque. And the one we are very interested in is carotid stent thrombosis. And this occurs in tandem lesion patients. So this patient actually have a stroke, we discussed it before, and this clot originates from an ongoing thrombosis in the carotid. So this is why they are called tandem, because they have two lesions. So when they come to the hospital, they have to be treated for ischemic stroke, so thrombolysis or thrombectomy, but they also undergo angioplasty with stenting. And this is to avoid stroke recurrence, because if you leave here the ongoing thrombosis, you remove the clot, another one will come. And here, a major complication is stent thrombosis. So let's discuss it. what are the determinants of stent thrombosis in the carotid, like in other vessels? So the stent, of course, that is thrombogenic per se, but also the plaque. I already discussed it. A plaque that is represented here contains lots of tissue factor, which activates the coagulation, lots of lipids that activate platelets, and lots of adhesive proteins that also activate platelets. So we know that the plaque is very thrombogenic. The stent is probably, but what do we know exactly? And how do we study it? So there are models that have been developed to study stent thrombosis. I represent, there are 5 models altogether, but I represent 3 here. Chandler loop, annular perfusion chamber, and the circular benchtop perfusion system. So they have been designed to study only coronary stents. The stents are usually inserted in tubings, or sometimes in flow chambers that are not mimicking vessels. So there is no consideration of the geometry of the vessel. In consequence, there is also no relevant blood flow conditions that are used. And we know that rheology is very important in thrombus formation. Finally, they only allow the evaluation of the thrombogenicity of the stent, not stent thrombosis. So what we did quite recently is develop macrofluidic flow chamber together with Nettel and Corinne in Technion. And what we do is we 3D print the lumen of any vessel. To illustrate that, here I've presented the coronary arteries, carotid or femoral artery. So you use a resin to 3D print, then you pour over PDMS. You remove the resin, and you end up with this type of chamber here representing the carotid. You have the common carotid here, the internal carotid, and the external carotid. And the reason why we're doing flow chambers at the exact scale of human vessels is to insert the stents, because you cannot use microfluidic devices. They are much too small, and they don't have the right shape. So this chamber were characterized by Nati's group using CFD, but also particle imaging velocimetry. So here, what they do is they perfuse liquid that has the same viscosity as blood, and they add beads to it. And you can see here, I'm not sure we see it properly, but you have recirculation areas that also occur in healthy individuals, in everyone here in this room. And you have this region of low flow where actually the plaque is forming, so the atherosclerotic plaque. So the chamber was then characterized. We inserted it in a closed-loop perfusion system. And with a peristaltic pump, we perfuse human whole blood through it. And usually we do this for 1 hour. So I will subdivide the talk here in 2 parts. First, what we did on stent thrombogenicity, and then stent thrombosis. You remember the difference is here. We just have the stent. We look at its potential to become thrombogenic. And here we have the stent and the plaque. Okay, so what we are interested in is the carotid. And the 2 stents that are extensively used in the carotid is the Casper stent and the wall stent. So the Casper stent is auto-expandable, made of nitinol and dual layer. The wall stent is auto-expandable, made of algiloy and single layer. To implant it, we had a neuroradiologist coming to the lab and showing us how to do that. We do it as in clinic, so we go inside with a catheter and then open the stent, so it lies as in patient between the internal carotid, where you have the plaque right here, and the common carotid. We then perfuse whole blood over it. That was stained with DIOC6 to label cells in green, usually platelets. In the control, no signal. And here you can see that we had signal forming over time. And this is the main result we got. So 2 observations. A more diffuse system over the stent, and then a very intense one in the bifurcation. So large thrombus in the bifurcation. And I will talk about these 2 results. So let's start with the large thrombus in the bifurcation. Again, nothing in the control. Large thrombus with a wall stent, also with the Casper, confirmed by quantification. We use scanning electron microscopy to look a little bit in detail. So lots of thrombi there, zoomed in, and you can see here, it's even difficult to recognize platelets, but you can see one here, one there, etc. They are all shape change, very much activated. So does this have any clinical relevance, or is this something just we observe in the lab? The answer is it does. So we conducted a retrospective clinical study in tandem lesion patients. So 117 patients from the hospital of Strasbourg. We looked at the one that had a stent thrombosis, 31 had it. So this gives 21%, which is in line with what has been published. And of course, this patient will all have a thrombus in the internal carotid where you have the plaque. But interestingly, 40% had one in the bifurcation where you just have the stent. So this suggests that 40% of the patients are having a stent thrombosis just because the stent lays there. So what is the reason for that? So that's where we are stopped. We don't know if we are not having collaboration with mathematicians, biophysicists that can explain things. So that's where Nati really was very helpful to help us to understand. So you run this complicated model that I don't understand. But anyways, what comes out of this study is that when you have this wire in the lumen of the bifurcation, it generates really high shear rates. And what he has predicted is shear rates exceeding 10,000 inverse seconds. And this is above the threshold at which flowing VWF will unfold. If it unfolds, we heard about it yesterday, it can bind to the wires and initiate thrombus formation. So this is most likely what happens here. We looked whether this thrombus formation is sensitive to the agents that are used in clinic to prevent thrombus formation. First, aspirin. It is the case. We have a very nice inhibition. We have thrombus formation, so it must also rely on alpha-2 beta-3, the one that allows the aggregation, and this is also the case. We have a very nice inhibition of thrombus formation. Can we propose a solution? So we contacted textile engineers in Germany. They are able to braid stents. So the first one that they braided is a closed stent, and then we asked them to braid an open stent. So you have this opening here with the idea to insert the stent in the bifurcation to not have this grid. And what we observe is this stent, for a reason we have not yet understand, is also forming a thrombus, but not as large as the commercial one. So this, even on its own, is a bit weird, and we should try to better understand what's going on. Nevertheless, there was a thrombus there, and known here, confirmed by quantification. So let's move now to the second observation, this more diffuse signal that we have here, so this smaller thrombi. Are there thrombi? Yes, there are. It's not because it's a small signal, because what you have to realize here is this is a couple of millimeters, so nothing to see with what people are doing in microfluidics. These thrombi are massive. And when we looked at this really small signal, you can see the thrombi here. When we zoom here, they're constituted of hundreds and thousands of platelets. This is already quite a large thrombus. Okay, so we looked a bit closer, and we had the same type of signal in the Casper and the wall stent. The signal seems to draw the wires, but not completely. You don't have the same image here than here. So why is that? We looked a bit closer and said, okay, let's look at the crossing and the region where there is no crossing. And indeed, what we observe is that the signal was concentrated in the region where you have crossing and nothing in the region where you don't have crossings. Then we looked even closer, and we called one wire the proximal wire, the one that is in contact with the wall, and the other one, we called it the distal wire away. And indeed, here as well, the signal was concentrated mainly on the proximal wire for the Casper stent and the wall stent. So here again, we need to discuss with biophysicists, mathematicians, to help us to model what's going on. And we saw that even though these wires are very close, the local rheology is completely different. On the distal layer, where you don't have thrombus accumulation, the flow is slightly high compared to a coronary artery. You would expect a carotid artery. In a carotid artery, you would expect flows with a shear rate around 900 inverse seconds, ranging, because you know it's pulsatile, from 0 up to 1,100. So it's a little bit high, but nothing too crazy. And when you look at the proximal wire, it's extremely low. So this, you are probably generating regions of low flow, where you have adhesive proteins from the plasma that can stick down, and then platelets have long residence time, and they can adhere and probably initiate thrombus formation. Very similar observation in the wall stent. Is it sensitive to the antiplatelet agents? It works not as good. Aspirin, we had a 50% reduction, and here it was even non-significant. So the standard of care that is used right now to prevent this process is not working really well. However, apiximab, so antituberous agent that you are not allowed to use in clinic because the patient might then bleed from in the brain, this works really nice. So this is not a solution. It works, it tells you the mechanism involved, but it's not a solution that you can use in clinic. So conclusion here, macrophilic chambers are well-suited tools to study intrasect thrombogenesis or clinically used stents. A stent lying in the lumen of the carotid bifurcation generates a highly thrombogenic flow profile. Stents crossing are hotspots of thrombosis, probably due to the low shear pockets formed around proximal stents. Platelet aggregation to stent relies on alpha-2 beta-3 and thromboxane 2 pathway. Openings in stent might represent a solution to limit stent thrombosis. Good. Last part. Now studying stent thrombosis. And of course, I go back to GP6. And the question we ask, is GP6 a good target to prevent stent thrombosis? So I presented this receptor earlier on, and you know now that glenzocimab is an agent that blocks glycoprotein 6 binding to collagen, but also other ligands. Again, stent thrombosis is a combination of the thrombogenicity of the stent and the plaque. So now in our models, how do we mimic a plaque? What we actually do is we obtain from vascular surgeons, sorry, that's in French, after a carotid endarterectomy, we obtain plaques. These plaques are cryo-crushed. We make homogenates. And when we immobilize them in flow system, you can see that we are forming very nice thrombi. So we decided to use these homogenates to coat them in the chamber and then insert a stent. So here we perfuse whole blood in a controlled chamber versus a chamber that has been coated with plaque material and stent, and you have a very nice accumulation of green signal corresponding to platelets. When you look into details, you have thrombi forming all over the place. We had this with, we did the carotid, but also the femoral artery. So here what we do is we use dedicated chambers. So we have a chamber for carotid, I presented it, but we also have one for the femoral with the exact same dimension. And we use plaque material from the femoral. In the two systems, we have nice thrombus formation, confirmed by quantification. They are both sensitive to the standard of care. It's not the same here. So for carotid, we used aspirin, very, very nice inhibition. With the femoral is the dual antiplatelet therapy. For some reason, inhibition is not as good. And then we tested glenzocimab. And glenzocimab had a very nice inhibition in thrombus formation, both in the carotid and in the femoral artery. Okay, and that's the last slide. Usually what we like to do in the lab is start with in vitro model and go to in vivo model. But there is no in vivo model of stent thrombosis in mice, so we try to develop one. We use this laser cut stents. They're extremely small. I even have a hard time to see them. But some young fellows in the lab are able to implant them in the carotid artery of mice. And in green you have platelets, and in red you have fibrin. So you can see that we have lots of fibrin and platelet accumulation on the stent. For now, they are too reactive, so we are working on them to set up the model. This is now more than 1 year of work, almost full time. So it's a lot of work to go there, but we hope one day to be able to achieve that. So conclusion 2, macrophilic chambers are interesting tools to study the intrinsic thrombogenicity of stents, the pathological process of stent thrombosis. Implanted stents modify the local hemodynamic to create prothrombogenic flows. A stent lying in the bifurcation generates high shear that appears thrombogenic. Stents crossing are hotspots of thrombosis, probably due to the low shear pockets formed around proximal stents. And GP6 is potentially an interesting target to prevent stent thrombosis in various vascular territories. We actually submitted sort of a grant to run a clinical trial in Strasbourg, but with what happened to Article Biotech, it was rejected. And I finish here just with some general thoughts. So arterial thrombosis remains a very deadly pathology, despite the fact that antiplatelet agents have helped to reduce morbidity and mortality of this pathology. We should keep in mind that arterial thrombosis is the consequence of a vascular disease, so atherosclerosis. So we will not be able to fully cure it just with antiplatelet agents and then anticoagulants. Probably think of eating, doing some more sport, drinking less wine, no smoking, etc., etc. I'm convinced that GP6 is a safe antiplatelet target. However, the question still is whether we will be efficient. So I think we will have one day the answer. There are several groups that are very motivated to go this path and test them in clinical trials. I didn't mention enough about flow alteration, but I think it's very important. Blood flow alteration by stenosis play a very important role in arterial thrombosis, and it would be very nice to develop strategy to block this process. And finally, the management of stent thrombosis has been greatly improved, but there is room to develop new stents and new pharmacological strategies to reduce carotid stent thrombosis. I finish by just showing the people that have been involved in this work and thanking you for your attention.
So thank you very much for this very clear, didactic, and excellent presentation, which is now open for comments and questions and discussion. Maybe Miss, yes?
I have two questions actually. Do you think that a drug that inhibits the GP6 receptor has some limitation in terms of shear rate, or it is applicable in all the ranges of shear rate?
No, we know it. We had a look at that. It's a tough question. Now, if you just look at the shear effect, higher the shear is, more an anti-GP6 has a role. So it has no limitation, I think, in shear-induced thrombus formation. Now, if you are going to extremely, extremely high shear, that might occur, like, at stenosis, where it's mainly GP1 BVWF dependent, maybe there it might have some limitations. But overall, it's a complex process. You always have, it's initiated by GP1 BVWF, but usually you always have contribution of platelet activation, etc. So this is not a limit. A limit will more of this target will more be whether, because it's an activation receptor at the end of the day. So it will more be if you have a soluble agonist, lots of soluble agonists, lots of thrombin generated. I don't think the GP6 will do more.
I see.
It wouldn't be too good to target it.
And when you talk about stent thrombosis and thrombosis in the bifurcation in which you put the stent, you tell that high shear rates, the thrombosis that you observed may due to high shear rates in the stented part that can induce the envelope of von Willebrand factor. But do you think that also mechanical platelet activation can play a role?
Look, that's another tough question because
sorry.
no, but, I mean, it's a very good one. There's few information out there, on mechanical activation of platelets. My gut feeling is that you know, the sensitive, and there are some mechanoreceptors on the platelet surface, no doubt. YAPTAs, piezo as well, GP1B is one. It has been shown by O'Jerry that alpha-2 beta, by Sean Jackson that alpha-2 beta 3 could be one. But my feeling is that like the real mechanosensor is von Willebrand factor. And that is, it unfolds and plays a very important role. I've never been really able to have conditions, flow conditions, that would directly activate platelets.
I see.
Yes, so yeah, I'm not sure about it.
Okay.
I'm just not convinced.
Okay, okay. Thank you very much.
I really think it's biological, and I really think that it's... then it depends the range of shear rate we're talking about, right? I suppose if you go to crazy values that are
I'm
absolutely
talking about
non-physiological,
shear rate higher
maybe.
than
Yes.
10,000. Thank you so much.
It was before, sorry. Ladies first, but not always.
Uli Kercher from Charité Berlin. I have a question. It was a very interesting talk, and I was surprised that you have both effects on the stroms in stents, the low and the high shear stroms. And my question is, would it be possible if you have a drug-coated stent to prevent both of them, or only the low shear thromb?
Okay, I suppose the low shear pockets, if you coat them, you might be able to reduce, for sure, because you would prevent, you know, we see that there is fibrinogen binding, it's low shear. At low shear, platelets do not require GP1B to bind to fibrinogen, and they can bind by themselves, so it's GP1B independent. So if you're able to block fibrinogen adsorption, this could work well. Actually, high shear as well, because for now, it's only a hypothesis. So we show that fibrinogen binds at low shear, but at high shear, we have not been able to show that VWF binds. It's not that easy to do because they are massive stents, actually. But yeah, indeed, if we are able to have surfaces that completely prevent plasma protein adsorption, it could be interesting. Yeah. I mean, we would love to go to since almost 2 years to stent coating and to play around with it. It's just we don't have time, but we would love to do that. Yeah.
But perhaps I have a second question. What is the flow difference between without stent at the bifurcation and with the stent? Because if you have no stent, normally there should be a stagnation point at this bifurcation, and so very low shear, right? And
yes.
And with the stent, it seems to be with your simulations, they are clear. It's very high shear rate. What is the difference in the flow? In what is?
Oh, you mean overall when we have or not the stent implanted?
Yeah. Yes, then there should be a stagnation point at this
where
bifurcation.
at the entrance, you mean?
There should be a stagnation point because there's division of the flow.
We haven't really looked. Overall, it's just overall. I mean, we didn't see much differences in blood flow with and without the stent. We had to go in the details and look around the stent strut to see differences. But we have not, Nati has not closely looked at this point whether it makes a difference or not.
Thank you.
And just to come back to the question before, coating is really important, but there's probably also a way to still play with the size of the stent struts. So it has been done a lot in the past 30 years. They have improved it a lot, made smaller struts, and you have less thrombosis, but there's still room for improvement, I think.
Actually, I want to ask, you had a study on stents and you checked their thrombogenicity, Casper and the other types. I just wonder that maybe I missed the point, but did you make a thrombus before replacing the stents in the microfluidic chamber?
No.
Okay.
What we did, we just implanted the stent and then perfused blood, and the thrombus is forming over the stent. We are perfusing for now 1 hour, and probably it's formed within 10-15 minutes.
Do you think that it is required, or I mean, making a thrombus before replacing the stent is required, or it's just an option?
I mean, the question is, how would we do the thrombus? Really, what we really wanted to see is when, you know,
because in the human anatomy, the surgeons are not replacing stents without making thrombus.
Oh, I see.
Yeah, that's why it's just mimicking the natural.
Yes. So what they usually do, it depends. You know, they come depending on whether you're an femoral, etc. They will either collect it or remove it, push it towards the wall, and install a stent. So, okay, you're correct. Sometimes there is an ongoing thrombosis. So here we placed ourselves only in a situation. So this was just to look, the first part, at stent thrombogenicity. Actually, this is absolutely not what was the project on. Our project was only on GP6, so we needed a model for stent thrombosis. We wanted to have the plaque and the stent. And it's only because when we implanted the stent that we saw a couple of things happening that we pursued. But you're right, we could also, what we could do is coat with the plaque material, perfuse blood, have a thrombus, insert the stent and look at it. The problem with this model, you know, when you do microfluidic, you can do 15 to 20 flows, correct me if I'm wrong, 15, if you have someone really well trained, 15 to 20 flows in half a day. With this model, because you need 100 to 200 microliters per flow. With this model, you need 150 milliliters of blood for 1 flow. So it's only because we are in the blood bank and we can just go downstairs and have a lot of blood that we are able to run these experiments, and you can do 2, maximum 3 conditions per day.
That was an excellent talk, Pierre. I really enjoyed it. I have some questions about signaling through GP6 that I don't think I understand with these different ligands. So what's the difference in the intensity of signaling when GP6 binds to collagen versus fibrin versus fibrinogen versus laminin? And does it have to do with the dimerization of GP6, or is it clustering of the receptor? Because it's obviously quite different.
Let me just check. Give me just a second. Okay, I wanted first to present this slide, so I'll go quickly through it, okay? So that's the view we have in the lab for now, because what we are missing is really agents that specifically block the interaction between GP6 with these 3 ligands. The day we have them, we will be able really to address this question. So it's a lot of speculation. There is no doubt whatsoever that collagen is the strongest activator through GP6. Then I would say much lower, just in terms of intensity of activation, right? Then much lower you have fibrin, and even lower you have fibrinogen. The reason is probably because of clustering. There's no reason to think that the signaling pathway is different, but no one investigated it. Now, having said that, we try to put it in the context of a thrombus formation, whether we're talking about, let's talk about thrombus formation, right? So when you look at that, and when you focus on collagen, what you realize is it's only the first line of platelets that interact with collagen and then transduce signal. All the other platelets, so 100,000, 10,000 platelets, are not interacting with collagen. I'm not saying this is not important, it's very important, and it's a very strong signal. And you know, it frees, it releases soluble agonists, etc. So it's very important for thrombus initiation. When, let's talk then about fibrinogen. Very weak interaction, of course, very weak interaction, but also very weak stimulus. But you have a lot, you have all over the place. So a little bit of a lot of bonds might be significant. And that's what we think. Now let's talk about fibrin, much more complicated. So here what we did is we used intravitreal model, and we looked at thrombus formation. So you have this peak, etc. But what you have to realize in this model is that the maximum of thrombus formation is already there, even though the maximum appears to be there. It's just that the thrombus grows along the that the thrombus still grows within the vessel, right? And when you look at fibrin, it appears with a delay. Probably it appears, we know it appears in the center, has been shown by the group of UPenn and many others. We saw the same result. So fibrin appears when the thrombus has already reached the maximal size. So saying that what we wrote in the Blood paper in 2015, that GP6 fibrin interaction is important for thrombus growth, I think we overinterpreted the result, maybe, but it's not sure. Its role, we don't know. Whether it plays a role in stability, potentially, right? So I'm not sure I answered the question, but yes, okay.
Well, just a follow-up question. I mean, what is, I know this is about arterial thrombosis, but is targeting GP6 for venous thrombosis where there's lots of fibrin? Is there evidence in animal models or otherwise?
Yeah, I mean, you know, it might be very different, and you know, if you have fibrin that we see as a weak adhesive surface, but under condition where you have someone generated, it's another story. Because what you need is something to attach and something to really stimulate. If you have this, it's like you get a big thrombus forming.
Yeah, a naive question from a physicist. So when you showed us the nice occurrence of the thrombus in the mice, and we see this nice development, we see a very nice parabolic profile of the thrombus. And so I was wondering, so at one point when the flow stops, any plumber will tell you that you have a pressure wave which will compact your thrombus. But in the mice, the pressure is not that high as in human. And so I was wondering if your drugs, the problem that it does not work that well, or it doesn't give you the good result compared to what you did in mice, could come from simply a plumber problem. So the levels of pressure and the compaction will not allow recanalization and all the process you described that was working with your drug. So again, a naive question.
I mean, I don't think I have the answer. I mean, it's a good comment, and we should discuss about it, because you know, there are lots of issues in mice to really work on recanalization. So it would be nice to discuss it and to see how we could modify it to get closer to the human system. I mean, there are lots of differences between mice and human, but there still fantastic tools to study occlusive thrombus formation, but also. So when we have the occlusion, occurring, we always see something that looks like a vessel contraction. So if I'm happy to show you some video. I don't understand it. I showed it to some biophysicists. They couldn't really explain it for now. But I would be very interested just to understand what it means. Just like a contraction.
I really like your presentation. I've got a question about the clinical trial.
Yes.
If you look at the composition of the thrombi that we extract from the intracranial arteries, you can basically find anything from a fibrin-rich platelet clot with no red blood cells to clots that have almost exclusively red blood cells. And there's, I guess, not a real good way to get that that knowledge a priori. Do you think that the composition of the blood clot in the intracranial artery has an impact on the outcome of your clinical trial?
They didn't look, so it's difficult to answer the question. Globally, most likely, from what I've seen in the studies from Benoît Autinoé and Simon de Meyer, so two different studies, wherever the origin is, so the etiology, these clots were always composed of platelets, fibrin, or also red blood cells. So it doesn't help to differentiate. But yeah, for sure, it has an impact. And you know, if you have a clot that is extremely platelet rich with lots of fibrin and even a fibrin cap, how do you want to really dissolve it with such an agent, right? So I would never have, I never push towards this indication. I work with them a lot, we characterize the agents, but I always suggested to go to other indications, but you know. And even there is no collagen there, so how could you really go to such an indication where you don't have the ligand, fibrin and fibrinogen? We've discovered it afterwards. So it was a surprise. We have potential explanation, but I don't think it's the best indication to go with. Now, having said that, and you know, once you have a recanalization, for instance, thrombectomy, thrombolysis, there are events in downstream circulation. I think we have a talk tomorrow on thromboinflammation, and maybe that's where an anti-GP6 agent, when it goes through, might be beneficial. So it might be not on recanalization, but it might be on reperfusion by actually lowering thromboinflammatory events. And then these events, actually what happens is the endothelium, because it's deprived of oxygen, becomes activated, videally exposed, platelets attached. And then you have leukocytes attaching. Then they can transmigrate and injure the vessels. Then you can bleed. So you might have an antiplatelet agent that can lower the hemorrhagic transformation.
Very, very nice talk. I do have a question about what you think about GP6 stability, especially at sort of super physiological shear rates, in the notion of potential microembolization.
So what do you mean?
So we just did some studies, some microfluidic studies, looking at super physiological shear rates.
Yes.
And we sort of stumbled upon some GP6 behavior by blocking it. And what we noticed is that we would observe more microemboli.
Mm.
And so when you sort of consider high degrees of stenosis,
yes,
right, the impact of some of the drugs that might actually induce microemboli and cause downstream issues.
Yeah, no, for sure. I mean, I have often this question, right? Because when we show the model where we block GP6 and we have emboli leaving, is it not harming more than it should, right? And you have, what's the name of the clinical trial? MOST. MOST trial came out recently looking at argatroban, so thrombin inhibitor, on top of RTPA. And what comes out is finally it harms more than it protects, right? And probably because of what you're saying, there is more emboli. So we really have, we should not be happy just to see that we have we dissolve the clot. We should be really careful at what comes downstream, yes, for sure. But this is very difficult for now to identify in mice. We have some models now. So there's a very nice model in Camp, Denis Vivien, set a very nice model to look at the microthrombi. If not, it's almost impossible. And you know, mice are very resistant. So sometimes they can have clot everywhere, but they're completely fine. So it's not the easiest to detect. But with this new technique, potentially we can combine looking at recanalization. And you are completely right. We should be really careful. The only thing is that when we have the same behavior when we use Cangrelor, that we know is really dissolving well the clots, and that also has this emboli. But I agree. I fully agree with what you said.
Yeah, thank you very much for the very, very nice talk. I had a question regarding your experiment with the adhesion of platelets in the first part of your talk. So when they adhere, they form clusters. What do we know about the size? How do we scale the size of those clusters, their shape? Do we know anything about it? Or is it just that we observe that there are clusters and that's it?
So you mean on collagen, right? So when we immobilize collagen, so I think that what we know is, or what I understand out of it is, if you perfuse, so you have two types of matrices. You have the high reactive matrices, you have aggregates, and you have the low reactivity matrices. You just have single platelet adhering. When you perfuse blood over low reactivity matrices, they are binding everywhere. When you do it on collagen, they bind at specific regions and form these aggregates at specific regions. Okay. The problem is collagen is a fiber, and you probably have regions of high binding and regions of low binding. So you could think that this is just due to the fact that not all region of the fiber is highly reactive, and you will have a region of highly reactive fiber, and that's where they will all accumulate. But I don't think it's like this, because if you block alpha-2 beta-3, if you prevent aggregation, you end up with you completely cover the surface, right? So that's not the case. So suppose that what happens is that first platelets adhere somewhere and will generate around it, modify the local flow, and facilitate the recruitment of the other platelets.
So this would be flow-induced. And so we clearly see the shape and the size of the clusters from the top, but what about the other direction? I mean, how high?
Yes.
What is the height?
Oh,
how many
so that's, I should have shown a video, but we use confocal microscopy. We can go through it. We can represent the thrombi in 3 dimensions. It can go up to, it depends on the channel you're using. We usually use channel 0.1 by 1 millimeter. So the thrombi can be 50 micrometers in height, and you can image it completely with confocal microscopy and represent it in 3 dimensions over time.
There is a poster on that.
So, any other question?
First of all, very nice talk. And my question is a follow-up on Frank's. You see the clusters. Can you tell whether they're growing upstream, downstream?
Yes.
And which way?
Downstream.
So they're not just capturing rolling platelets coming from upstream that are attaching to the front end?
Yeah, I had a great video on that. They're really, the first is attaching and the other one are coming just after it. It's good. They're really growing in such a direction. Even the thrombus is really going backwards. I don't know if this for physicists or mathematicians makes sense, but this is what we observe. Yes. Okay. Okay. Yes. Yes. And then they come behind it. And
other question? Well, maybe a last one, a very special one, of course. You've shown us very striking results on therapeutic developments targeting cell surface receptors. Would you currently bet on any therapeutic development on platelets, of course, targeting intraplatelet signalization?
Yes.
Do you have any feeling on that?
I mean, I've been in a... Yeah, I mean, there's no doubt that, platelet activation is extremely important in the process, and aspirin works like that. A long time ago, I've done my postdoc in a lab in Australia where they worked on the PI3 kinase beta. I think it's very important, and this is right now in clinical trial for treatment of ischemic stroke. I don't have all the results, but I think it looks really good. So there are ways to inhibit platelet functions through targeting signaling molecules. The problem is it's often shared by other cells, and then you increase the chances to have side effects or additional to bleeding. So I prefer to focus on just platelet-related molecules, but there are other ones like alpha-6 beta-1. This is a surface receptor that is really interesting. It's probably the most important beta-1 integrin on the platelet surface. It is found on other cells. We don't know yet if we want to follow this path or not at inhibition. We are not, in the lab, we are not looking at intramolecular pathways, at least to block them. We are more focused on receptors. But again, there are labs doing the work, and PI3 kinase beta is a very interesting one.
Thank you. Maybe another little one. I've seen no data on the importance of leukocytes in your models.
Yes.
Would you comment?
Yes, of course. I mean, so all the in vitro models, they are not important. Okay. We are in model where we look at them for sure. We are not on the condition under which we are able to recruit them. However, we can modify the models, and we are doing it right now, to look at platelet leukocyte interactions. when we have the specific question. We discussed before the thromboinflammatory events, so we are developing model to look specifically at that. Looking now at in vivo models, we are more focused on arterial thrombosis. We are always in our models inducing vascular lesions, and we do never see leukocytes arriving before platelets. However, if you go to models like Bruce Fury's model, Christophe Dubois, he is just activating the endothelium. It's nothing negative in what I'm saying, right? He's activating the endothelium, releasing probably VWF, allowing leukocytes to activate, and then seeing thrombus formation. So it's just, we should just think about what it represents in pathophysiology, and probably these are model closer to thromboinflammation. So we don't have yet the model, but we are going, since we have this question now about, reperfusion lesion, we are moving to this model as well.
Thank you so much. No question? So thank you so much for this fantastic lecture.